Welcome to the topic on headaches. This is a big topic, far bigger than we can discuss in a short space of time. However, it's important that everyone has an idea about various categories of headaches, how to diagnose different types of headaches, to make sure you've excluded out any of the red flags, and when to refer on as well. And I suppose to have an idea about managing these patients, because it doesn't mean if you've got a headache you need to see a headache specialist. Sometimes pain specialists can do more for some of these patients. So this is the way we're going to structure the talk. I'm going to spend some time talking about the primary headaches, so migraines, tension type headaches, cluster headaches, talk about the trigeminal autonomic cephalalgias, and then speak about something that I never really got a handle on until I started doing pain medicine, and that's the chronic headaches, the daily headaches, the medication overuse headaches, and the cervicogenic headaches, which is important for us as interventionalists, and then just a bit about neurostimulation and red flags, which are of course vital. So the red flags should come at the beginning, but we'll discuss red flags down towards the end. So the basic bottom line is headaches are common. They're probably the most commonest complaint that patients have. And there you can see, even in the 1800s, we were getting fantastic cartoon drawings about headaches and how debilitating they can be. So if you have a look at that, this guy's completely, he looks pretty broken by his little demons that are causing him pains in his head, in his ears, smashing his head. Looks like there's, oh, that's a hat. So there's a lot going on. And this was drawn by the guy in the corner, who is George Cruikshank, was a cartoonist in London in the 1800s. It's a very, very common problem. If anyone needs to have a look at one article with regards to headaches, this has been classified as the most important article for anyone to have with regards to managing patients with headaches. And this is the International Classification of Headache Disorders by the IHS, the International Headache Society, and this is published by Cephalalgia, which is the headache journal. So I recommend that you go ahead, and there's a short version, there's a long version. It is an open access article, and it essentially just classifies headaches, and this is where I've got the classification that I'm about to show you from. So this is the basic gold standard classification of headaches, and of course there's a website with various discussions as well, so I direct you to the website if you have an interest in this. So this is based on the classification, and it's pretty simple. This table shows you that they're primary headaches, they're secondary headaches, and then they're cranial neuralgias. Now the cranial neuralgias are things like trigeminal neuralgia, glossopharyngeal neuralgia, optic neuritis, occipital neuralgia, burning mouth syndrome. So it's a neuralgia of the head. So that's the cranial neuralgias, but we're going to focus on the primary and really importantly exclude secondary headaches when we see our patients. So the primary headaches are four primary headaches. There's migraines with or without aura, there's tension type headaches, there's the cluster headaches and other trigeminal autonomic cephalalgias, and then there's the other. And under the other are things like primary stabbing headache, cough headache, exertion headache, and a couple of other things. The ones I'll draw your attention to are hemicrania continua, which we'll talk about briefly at some point, and new daily persistent headaches as well. These are probably for headache specialists, but it's important that we've got a handle on this. And then of course the secondary headaches, of which the important ones are substance use and withdrawal, and secondary headaches caused by problems in the musculoskeletal system of the head and neck. So migraines, there's the WHO symbol, and they consider it, or migraine is considered a chronic neurological disorder. It's probably one of the most common headaches. It's certainly, the WHO classifies it as one of the most 20, it's in the top 20 as far as debilitating diseases goes, or debilitating illnesses goes. And what migraines is headaches, head pains with a number of associated features. And as you can see, it occurs more in women than men. And most of the migraines are without aura. We all know the aura migraines, but 8 out of 10, not 9 out of 10, 8 out of 10 times it's actually without aura. So there you can see the age and gender relationship with migraines. The top pink line is with aura in females. The bottom pink line is without aura in females, and then the blue lines are with aura, without aura in males, and with aura in males. So it's common in younger age groups, and it's certainly much more common in females than males. So this is the criteria for migraines with aura, and I don't want to spend too much time going into the finer details. I've given it to you so you've got a reference point. Some of you might be interested in this, and so you can read a bit more into it. But there are things that need to be done, and you need to have at least 2 attacks to fulfill criteria B, and criteria B essentially is at least one of the following with no motor weakness. That's very important, of course, because if there's motor weakness, there's something going on, and that needs to be actively excluded. And you've got reversible, that's the key visual symptoms, which include positive and negative features. Reversible sensory symptoms, which include positive and negative features. And then, of course, reversible dysphasic speech problems as well. And the key is reversible. The key is it's fully reversible, not partially reversible, and there's no motor changes. And then at least 2 of the following: homonymous visual symptoms and or unilateral sensory symptoms, and then at least 1 aura that develops over 5 minutes, and with or without and or different aura symptoms occurring in succession over 5 or more minutes. So again, the numbers are not that important for us, but it's the fact that there are strict criteria if you choose to diagnose migraines. And a lot of people don't do that. A lot of people said, you know, get a couple of flashing lights and, well, you've got migraines. Well, I think because we've got these reference points, we need to use these reference points, particularly with the chronic headaches, because chronic headaches are very often, and I see a lot of it. Okay, so that's the classification of migraine with a typical aura. And auras are not always typical as well. And here you can see various kind of representations of the different kinds of visual symptoms and phenomena that patients can get when they get migraines. So the top one with the little red kind of fort is a fortification spectra, and it's exactly what it is. It's changes in the visual field that represent this kind of spiky kind of circular shape that essentially looks like a fort and the bastions of a fort, such as we all know from our history lessons of years gone by. So fortification spectra, scotoma are changes in visual field, sometimes centrally, and you can get positive and negative changes, so darkness and brightness, and then of course you can even get unilateral visual loss as well. So this is a graphical representation of scintillating scotoma as well, so flashing lights, possibly in a kind of circular phenomena around the center of the vision, or the center of the visual field. And there is another representation of what it might look like to migraine sufferers. Photopsia, flashing lights, as you can see, common as well. And I just want to remind you that there are various phases of having a migraine. There's the prodromal phase, there's the aura, the headache, the resolution, and the postdromal phase. Migraine without aura has some criteria as well, and you get headache and descriptors of the headache, and then you get associated symptoms. So the headache is unilateral, it's pulsatile, and the key is it's moderate to severe in pain intensity, and it's aggravated by physical activity, physical exercise, and we'll compare this to tension type headaches in a little while. Nausea and or photophobia, and phonophobia. And of course we must exclude either secondary headache disorders or secondary causes of headaches. So let's move on to the mechanisms of migraines, and it's important to have a handle on the mechanisms, and there are a number of potential mechanisms out there, or potential theories on mechanisms, and they have changed over the years, but there are 4 main big ones. There's the vascular hypothesis, There is a neurovascular hypothesis, which means that neurological changes lead to vascular changes and then hence the headache. Or there's the vascular neural hypothesis, whereby vascular changes lead directly to neural changes, or sometimes even indirectly. And then there's the genetics. So let's just talk briefly about the vascular changes. It is known that vasodilators trigger headaches. If you give patients GTN and various other vasodilators, they get headaches, they get migraine type headaches, some of the patients as well. And the vasoconstrictors relieve those headaches. So it is a vascular phenomena. It's a vascular phenomena in the head area, in the trigeminal area. As time has gone on, we're looking more into a neurovascular phenomena whereby neural changes and so-called cortical spreading changes or cortical spreading depression changes occur from bottom upwards of the cerebral cortex, whereby you get this kind of metabolic change, this neurogenic change that can lead to changes with that can lead to changes in the vasculature. So-called metabolism flow coupling and various pro-nociceptive neurotransmitters, peptides have been found, which include things like CGRP. So vascular, yes. Probably neurovascular, yes. But even more recently, it's considered that it might be a vascular neural phenomena. So changes in vascular elements such as endothelin-1 can indirectly lead to neurological changes, and there is some evidence out there to support this as well. So it's a neurovascular disease. We're not sure which one came first or comes first. And then genetic component is very important, particularly talking about the familial hemiplegic migraines, of which the three big ones are the CACNA1A gene abnormality, so that's the calcium channel, the ATP gene abnormality, which is the ATP channel, and then the SC and the sodium gene abnormality. And I think there are a number of other familial hemiplegic migraine variants as well, or there might be more. When you're managing migraines, it's easy. This is the way you're managing most headache disorders, and this is from a pain perspective, a multidisciplinary perspective. Make the diagnosis. So use those criteria that we discussed to actually make the diagnosis according to recommendations by experts. Always exclude the red flags, exclude the secondary causes. Education is very important for all these patients. They need to know what it's about. They need to change their lifestyle. They need to recognize triggers and avoid the triggers, so they need to understand what those triggers are. And then you can want to define the type and frequency of attack that may change the management. Very important, treat comorbidity. Migraine sufferers have comorbidity, particularly depression and anxiety, so treat those. Again, it's a multidimensional, multimodal kind of pronged approach. Headache calendars and diaries are useful. Individualizing treatment, of course, everyone needs that. And combination therapy is important. So what you're seeing here is an approach that is what a pain management or pain specialist, the way a pain specialist would approach these patients. Medical aspects, physical aspects, functional aspects, psychosocial aspects, psychological aspects, and then the education part of it. So this is standard stuff. So if you're talking about migraines and you forget about all these fancy triptans and ergotamines that should be or shouldn't be used, go back to your basics, go back to your exclude secondaries, make the diagnosis, recognize changes, triggers, lifestyle changes, etc. So we've got a handle on this. And then the evidence is there, and depending on where you look, there'll be various studies that have appraised the evidence and given recommendations on the treatment of acute migraine and the treatment or the prophylaxis for migraines. And I've just used one paper from the a Scottish guideline network, and we're looking at acutes and prophylaxis. So if you have a look there is evidence out there, and it's fairly decent evidence to support anti-inflammatories, paracetamol, triptans, and antiemetics in the use for acute migraines. And then prophylaxis, beta blockers, yes. Propranolol, yes. Antiemetics, there is evidence out there to suggest, and this is what it's saying, topiramate, valproate, and gabapentin can be useful for prophylaxis for migraines. Antidepressants, tricyclics and venlafaxine, there is evidence out there. Not recommended, ergotamine, and it's in there in italics to remind us that it is useful and it can be used, but the side effects are significant, so it shouldn't be used first line. Opioids are there. Opioids are not a treatment for acute migraine, and we see it a lot. They come in with an episode and get their shot of opioids and off they go, and this is not appropriate management for migraine sufferers having an acute attack. Antidepressants, the SSRIs, are not recommended for prophylaxis, and botulinum toxin is not recommended for prophylaxis for acute migraines or prophylaxis for migraines. It is useful in chronic migraines, and we'll mention that later on, but it is not useful for acute migraines and prophylaxis for migraines. So tension type headaches, again, there are diagnostic criteria. It is the most common primary headache disorder. We've all probably had a headache, and we've all probably had a tension type related headache. It is prevalent, as you can see. And the thing about it is, which I didn't get, is that there is overlap between tension type headaches and migraines, and they do often coexist in the same patient. So they're having a migraine attack, then they're having a tension type headache attack. The criteria, they're headaches and autonomic symptoms. Headaches are pressing and tightening, so slightly different. It's only mild to moderate compared to a migraine. It's bilateral, and it's not affected by exertion. And you can have photophobia or phonophobia. No nausea, vomiting. Nausea, vomiting with headaches is quite a good screener for migraines. So migraines, it's unilateral, we're just comparing back to migraines. It's pulsatile, it's moderate to severe, so not mild to moderate, and it's aggravated by exercise. So it gets them lying down, it gets them immobile, whereas a tension type headache, they can still do stuff. Okay, so let's back to the tension type headaches. Pressing or tightening, it's a mild or moderate headache. It's bilateral, and it doesn't change with exertion. A reminder on the pathophysiology, or the likely pathophysiology, etiology of tension type headaches. Muscles. Muscles are important. Temporalis muscle, frontalis muscle, various other muscles of the head and neck. There's sternocleidomastoid, masseter muscles, and as you can see, there are a lot of muscles that can be responsible for tension type headaches. There is a myofascial type syndrome. But the myofascial component to it does lead to, and there is evidence to suggest that there is a central sensitization aspect to tension type headaches. And that's important because we know that central sensitization needs to be diagnosed, and it needs to be treated differently to purely a peripheral kind of pain generator. And there is changes to descending inhibition as well. There is some evidence to suggest that that is limited in tension type headaches. And also, very importantly, you've got there Sigmund Freud and all his colleagues, that there is psychological component to tension type headaches, and again, some evidence to suggest this. So a number of aspects suggesting slightly different pathophysiology to tension type headaches compared to migraines, but again, overlap. I think we've seen this slide before. Treatment of tension type headaches, forget about all the evidence for and evidence against. It's the same basic approach, particularly if there is an overlap between tension type and migraine, or that they are common in a number of patients, so the two exist in one patient. So I'm not even going to say this. Yes, let's just move on. So treat the patient first. And then you might go to the evidence to guide you in various treatments. And there's not a lot of evidence out there. There is not fantastic papers, but there is evidence for, and there is evidence that things are not recommended. So the treatment of acute tension type headache is different from migraines. Non-pharmacological treatments do help, so relaxation, EMG biofeedback, and CBT definitely helps. Pharmacology, simple combinations, yes. Caffeine, no, because of the problems with long-term use of these medications, which we'll come to. Triptans, not recommended in tension type headaches. But how do you diagnose the two? What if there are features of migraine? It is difficult. It is difficult. But nevertheless, looking particularly at tension type headaches, not recommended the use of triptans. Prophylaxis for chronic tension type headaches, antiepileptics, yes. Antidepressants, yes. Non-pharmacological and pharmacological, yes. So it's almost similar, really. Cluster headaches. Just have a look at that picture. That is a drawing, I presume, by somebody that knows what a cluster headache feels like. I understand them to be one of the most intensely painful conditions that people can suffer from are cluster headaches. And that's a pretty good description, or pretty good drawing. So cluster headaches are one of the three main trigeminal autonomic cephalalgias. As you can see, it's a primary headache disorder, and it's quite a good question to talk to candidates about because it is quite unique in a number of features. It is the TACs, trigeminal autonomic cephalalgias. Short, unilateral, severe bursts of pain. There are changes within the autonomic nerve. There are changes within the trigeminal nerve that resemble autonomic features. The headache is mainly side-locked, so one side. Why is it called a cluster headache? Well, it occurs in clusters of headaches. So these clusters last about 6 to 12 weeks. They last for about 1 to 2 years. So these clusters of weeks where you get these headaches repeatedly, and then it disappears and then it comes back again, normally a couple of times a year, every couple of years. Interestingly, it can happen at the same time in the year, so there is a circadian type feature of cluster headaches. It is thought that the hypothalamus plays a key role within cluster headaches. So migraine, neurovascular, genetic, tension type headaches, myofascial, central sensitization. There's also central sensitization in migraines as well, and that's important, but I think we could pretty much assume that. And then cluster, hypothalamus seems to be the key feature there. And then their changes, their parasympathetic hyperactive changes and sympathetic impairment changes, and normally occurs on one side. So parasympathetic rhinorrhea, lacrimation, suggestive of parasympathetic hyperactivity in that distribution on that side. And then sympathetic impairment, so meiosis and ptosis as well. Cluster headaches. You get a headache, there's some autonomic features, and these are the criteria to diagnose cluster headache according to the IHS. Severe, unilateral, they can last for 15 minutes to a good few hours. Orbital, periorbital, temporal. Rhinorrhea, lacrimation, sweating, meiosis, edema, ptosis. So parasympathetic hyperactivity, sympathetic inactivity. Cluster headaches, the management. There it is. Forget about the unique treatments. Treat the patient. Consider all the simple things first. Really put your multidisciplinary hat on first. Exclude secondaries. Make the diagnosis. Educate. Do the changes. And then attack it from our five-pronged approach. Medical, physical, functional, psychosocial, and education. And then you might think about the unique treatments for cluster headaches. Interestingly, I never knew this until I started reading up on cluster headaches. Subcutaneous sumatriptan, yes. Oxygen, 100%. Don't ask me why that is. That is the evidence. Intranasal lidocaine, yes. Oral ergotamine, yes. Again, sumatriptan, oxygen is where it's at for acute episodes. Prophylaxis, there is evidence for verapamil, topiramate, and lithium, interestingly. And then I've got steroids and methylpseudoxide in brackets, not in green, because they are used, but the evidence is not significant or very strong for them. And then deep brain stimulation, has been used to treat intractable cluster headaches. Now we're talking about cluster headaches, so I just wanted to briefly mention the other trigeminal autonomic cephalalgias, so the primary headache. Proximal hemicranias, it's temporal, and indomethacin, interestingly, is a treatment. Short-lasting unilateral neuralgiform headache with conjunctival injection and tearing. Fantastic name, SUNCT. Less severe, you can get up to 200 episodes a day. It can occur over seconds. There's tearing, and interestingly, the pain can linger between episodes. Hemicrania continua is in brackets because it has features of trigeminal autonomic neuralgias, but it doesn't actually classify it under trigeminal autonomic neuralgia. So perhaps a neurologist will be able to tell us exactly why it is not classified under the TACs, but nevertheless it's there, it's side locked, it's got features of migraine, and it also responds to indomethacin. So chronic daily headaches, this is important because we see people with chronic pain. I see people with chronic neck pain, chronic head pain, and there's a big overlap, and a lot of the patients have chronic daily headaches. And the definition, headaches on 15 days of the month, at least 3 months, and they can be short duration or long duration. And of course chronic daily headaches can be primary or secondary, so you still have to exclude the secondary causes of chronic daily headaches. Now, I'm not saying investigate these people for years and years, but investigate, exclude all the secondary causes, and then move on. Get them into that chronic disease paradigm. So short duration, less than 4 hours, chronic cluster headaches, paroxysmal hemicrania and sunct, so short duration, chronic daily headaches. And then the long duration chronic daily headaches, which are by far the more common. Chronic migraines, so the transformed migraines. Chronic daily headaches with migraine criteria on more than 8 days. So they need to have the migraine criteria on more than 8 days of those 15 days. So they don't have to have 15 days a month of migraines, but they need to have criteria for migraines on more than 8 of those days. The other ones are chronic tension type headaches, so transformed tension type headaches, hemicrania continua, which we've mentioned, new daily persistent headaches, which is an interesting one, and I haven't got my head around that yet. But it is something that happens. It's a chronic headache. It seems to patients are able to tell you exactly when it happens. It's got features of chronic tension type headaches, and there are some migrainous features as well. So again, I'm pretty sure I couldn't diagnose a new daily persistent headache, but it's important to be aware that it is there. And the big one, the big chronic daily headache, particularly for us, are the medication overuse headaches. That is a huge problem. And there it is. I've just wanted to highlight the new daily persistent headache. It's a unique kind of headache. It's a chronic headache that all essentially just starts off chronic. It starts off on a day, and it has features of chronic tension type headaches and features of migraines as well. So it's quite a vague phenomena. Let's spend a bit of time talking about medication overuse headaches. You've got the diagnostic criteria according again to the IHS, the International Headache Society. If you use ergotamine, you need to get a headache on 15 days of the month. You need to take the ergotamines on 10 days of those per month, so 10 days of a month, and it needs to happen for 3 months. Same thing for most medication overuse headaches. You need to have a headache on 15 days of the month. You need to take the medication on 10 days of those months for 3 months. So that is the definition. That is how you diagnose it, and I've got a lot of people that take medication. The interesting one is the analgesic overuse headache. So the simple analgesics that patients use, headache on 15 days of the month, and that's for 3 months, but they need to have taken the simple analgesics for more than 15 days of the month, not 10 days of the month. So that's a standout one, just to make it a bit more complicated for us. And then of course the combination medication overuse and their substance withdrawal, so caffeine and opioids. We've all had a caffeine headache withdrawal. Common to all of these is that the headache worsens during medication overuse. So as they increase their medication use, the headaches worsen, and the headaches go away once they stop their medication. So you need to have been off them for about 2 months, and at that point medication overuse headaches will disappear. So it's almost a diagnosis that you can make retrospectively once they're off the medication. So the treatment of chronic daily headache, well, there you have it. Nothing new to you. exclude secondaries, make the diagnosis, education, lifestyle changes, trigger point, recognizing triggers, and then treating comorbidities and having our 5-pronged chronic pain, multimodal, multidimensional approach, multidisciplinary approach. For chronic daily headaches, there is evidence for what I've just shown you: anticonvulsants, topiramate, gabapentin, and valproate. Antidepressants, amitriptyline, fluoxetine, interestingly, that's an SSRI, so that's a standalone thing. I probably wouldn't use it because I'm not familiar with or comfortable with those medications. And the neurotoxins, there you've got it, botulinum A, so there is some evidence for Botox treatment for chronic daily headaches. Medication overuse headaches, there you have it. It's simple. Revert back to your basics for these patients. Need I say more? And then the definition for medication overuse headache specifically is define the medication, define what they're taking, how much are they taking, how long are they taking it for, so make the diagnosis. You can stop the combination, so the combination treatments, the triptans and ergots, you just stop. There is evidence to suggest that stopping is safe. But if you've got patients that are on butalbital, you need to taper, and butalbital is a phenobarbital, and it's a paracetamol, caffeine, and one of those phenobarbitones. It's a USA drug, and I have no familiarity with it at all. Treat the symptoms, so treat the withdrawal symptoms using anti-inflammatories and corticosteroids. Corticosteroids I'm not comfortable using, and I would need to phone a friend if I was going to do that, but there is evidence for its short-term use, and using preventative medications as well. So cervicogenic headaches, because we see a lot of it, I just wanted to briefly bring it to your attention. There is a good article that's referenced in the reading package. It's quite a thorough article as well, and these are excerpts from that article. Now, there are secondary headaches, so it's a secondary headache, not a primary headache, that arises from bones, soft tissues of the neck mainly. They're unilateral, they're occipital, frontal, temporal, and orbital, moderate to severe, and I presume that can lead to some functional impairment and all the other phenomena that occur. The attack can last hours or days, so it can be long-lasting pain. And here are the unique features that might help the diagnosis. There are triggers, so the triggers are movement of the head and neck, or movement of the neck particularly, and then palpation in the suboccipital region, the C2, 3, 4 regions, the greater occipital nerve, and even various things like coughing and valsalva maneuvers can trigger these bouts. So it's so you could call it a mechanical type headache. The range of movement of the neck is limited in these patients again, so that's a unique feature. You might want to focus on that. But of course, to throw a spanner in the works, there are some migrainous features in some of these patients as well, so you might head off on the wrong pathway. And again, who knows, they might coexist as well. Now the treatment, the unique physiology or pathophysiology of cervicogenic headaches is the trigeminal nerve, and there is common link between the trigeminal nerve and various structures of the head and neck, so neurological structures. So there's the V1, V2 distribution of the trigeminal nerve. And then you've got the C1 nerves and nerve roots, the suboccipital nerve from C1, C2 leads to greater and less occipital nerves, and C3 is the third occipital nerve. And of course there's a lot of overlap between this. This is very simplistically put, so that the cranial nerves, or the C1s, 2s and 3s, overlapping with the trigeminal nerves, and that's where these sensory components have a common kind of meeting point deep down, probably within the trigeminal nucleus. So referred type pain really. And there's the atlantoaxial joint, so the and the atlanto-occipital joint, so atlanto-occipital joint, atlanto-axial joint, and that's a key feature of the generation of cervicogenic headaches, the problems in that area. Hard to diagnose, but if it's on your radar, you'll probably pick it up. And there's the overlap. You've got the cervical nerve dermatomes towards the back of the head and the trigeminal towards the front of the head. So it makes sense that there's going to be an overlap, really. So structures in the back of the head, the back of the neck, can lead to pain and headaches in the front of the head. So cervicogenic headaches. And there again, it's just a picture of the great occipital nerve. We seem to be focused on the great occipital nerve quite a lot these days, with some fancy treatments as well. Treatments for cervicogenic headaches, well, it's a multimodal approach, multidisciplinary approach. So pharmacological treatments, non-pharmacological treatments, anesthetic or interventional treatments for us, some of us that are interventionalists. So blockades, radiofrequency, and then even surgical procedures can be done and have been done in the past. And these are the things we might do as pain specialists. The great occipital nerve blocks, less occipital nerve blocks, third occipital nerve blocks, joint blocks, again, we're falling out of favor for joint blocks, facet blocks possibly, but the medial branches, yes. Intervertebral discs as well might be a focus of pain. Neuromodulation, I just wanted to briefly mention neuromodulation and headaches because it's a lot of the time both are discussed. There is evidence that neuromodulation can improve intractable occipital neuralgia, cluster headaches, migraines, and some other headaches. And as I've mentioned, deep brain stimulation for cluster headaches and SUNCT as well. The evidence is not fantastic, but it's out there and it's gathering momentum. So it might be useful in select patients. And then I wanted to remind you, whenever you see somebody with a headache, even if you think there's absolutely no way this is a secondary headache, please just go through it in your mind, really consider it. And the worrying things, or the important kind of red flags, are if the headache is new, it's a different headache. If the headache changes, somehow one of the features or two of the features change. A thunderclap headache, that's exactly what it is. It gets bashed on the head and the headache is there from nothing. It's the worst ever headache. Yes, if they've got focal neurology, you're gonna put them in a scanner. You're gonna make the diagnosis quickly. Headaches in over 50s, and again, new headaches in elder people, and if they've got the other kind of red flag features, so fevers, weight loss, and other things, jaw claudication. So I just wanted to remind us that we all have limitations. It's important to know about headaches, and I don't read cephalalgia, but I know neurologists that do, and those are the people that I'm going to phone if the very basic things that I do for some of these patients are not useful. So always turn to a colleague that knows about headaches. That leads us to the end of this discussion.